Okay. I thought I would just start, and we don't, neither of us have any slides actually, so we're just gonna, yeah. So I thought I would just kind of start with reviewing some of the information that's particularly relevant for African Americans as far as risk and some of the statistics regarding GYN cancers in African Americans, specifically focusing on breast cancer information. So I think a lot of us have a general sense that African Americans don't do as well when we're diagnosed with cancer, and there's ongoing research as to what the reasons are for that. And it's interesting that white women are actually more likely than African Americans to be diagnosed with breast cancer. When we look at how likely people are, we look at what's called an incidence, which is the number of new cases usually looked at for 100,000 people in the population. So in the United States, that incidence for whites is actually 132.5 people per 100,000 each year are diagnosed with breast cancer. For African Americans, that number is 118.3. So it's slightly lower, which I think is probably somewhat of a surprise to a lot of people. But when we look at how people do once they're diagnosed, African Americans do worse. And that's not just for breast cancer, that's for ovarian cancer and cervical cancer as well. So when we look at how likely people are to die from breast cancer specifically, and again, we look at it in terms of per 100,000 people in the population, that number for African Americans is 33.8, so almost 34 people out of every 100,000 who are diagnosed with breast cancer will die from it, whereas for whites that number is 25. So even though whites are more likely to be diagnosed with breast cancer, they're less likely as a group, as a population, to die from it. And there are a number of factors that likely explain that. One reason is that African Americans tend to be diagnosed later, so the cancer tends to be more advanced when it's diagnosed, and then less amenable to treatment. So just less successful with the treatments. But an interesting point is, regardless of what stage African Americans are diagnosed at, they do worse at each and every stage. So even if it is picked up early, again, compared to whites, African Americans do worse. So then we sort of want to think about what some of the reasons might be from that. And it's not entirely clear, but part of it is probably that as African Americans, we're less likely to get treated right away for a number of reasons, and we're somewhat less likely to get high quality treatment. So those are some of the things that, even if we're diagnosed at an earlier stage, can make the treatments less successful. And then there is also evidence that African Americans tend to be diagnosed with a more aggressive form of breast cancer in particular. So even, so taking these other factors into consideration, if it's a more aggressive type of cancer, it's just going to be harder to treat. Treatments are going to be less successful, and so that's another reason that African Americans have a higher mortality rate or higher death rate from breast cancer than whites do. And then when we look at the other common cancers that affect women, so cervical cancer, uterine cancer, which is also known as endometrial cancer, African Americans are more likely to be diagnosed with them in the first place, and as with breast cancer, more likely to die from it once they're diagnosed. So there are a lot of opportunities out there for us to make changes in awareness, education, treatment. I think, on all sort of levels to try to make a difference in some of these numbers. And so there are a lot of factors that lead to why a woman develops one of these cancers. And I'll focus on breast cancer. Um, and maybe, I'm sure you're aware of some of these risk factors already. And risk factors, anything that increases the chance that you'll get a particular disease. So, uh, so do you guys have any ideas of what some of the risk factors are for breast cancer? That's exactly right. Right. So there's a genetic component, a hereditary component, and if a first degree relative, which is your mother or your sister, is diagnosed with breast cancer, then that increases the chances that that you will develop it as well. So that's an important one. What are some of the other things that make it more likely for one person to get breast cancer than another? Right. So, and what that gets at is exposure to estrogen. The hormone estrogen seems to play a role in developing breast cancer. And so, women who are exposed to estrogen longer through their lives are more likely to develop breast cancer. So, if you start having your periods earlier, relatively earlier, less than age 12, that increases your risk. Similarly, if you go through menopause at an older age, that increases your risk because that's just more years that your body's making estrogen, and that is why having children has an impact on your risk. So when you're pregnant, you're not exposed to estrogen. So women who have not had any children have a higher risk of developing breast cancer, as do women who have their first child after age 30. So all of those risk factors have to do with exposure to estrogen during your lifetime as a woman. Um, well, actually, that's kind of the same thing. So any other um, ideas? Uh huh. Yeah. So I think I'm not actually I'm not as I don't know that for I'm not sure for breast cancer specifically what type of radiation exposure. Um, yeah. Hmm. Right. 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 Yeah. So definitely a number of treatments for other types of cancers in general increase the risk of developing a second cancer later on in life. Any ideas about sort of lifestyle things that might affect the risk of breast cancer? Actually, smoking's not a risk factor for breast cancer. Hmm. Hmm. Yep, you're absolutely right. And the thinking for that goes back to the estrogen. So our bodies actually make estrogen in part in our fat cells. And so being overweight or obese, particularly after menopause, is another case where the body is sort of making more estrogen, and that exposure can increase the risk of breast cancer. Absolutely. Yes. Hmm. 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 Yeah. So mhm. You're absolutely right. Yeah, and I know there's a lot of efforts going into thinking about why that's happening, but it is something um, that's very apparent. I'm sure we've all sort of seen it as far as not just getting their periods, but sort of developing at an earlier age, and that is something that is hormonally driven. And so starting your periods at age 9 or 10, let's say, instead of 12, is something that increases your risk. And since that is more common in African Americans, that's something that, definitely plays a role. Mhm. And we often try to think about them as modifiable risk factors. So those are things that you have some control over that you can change. So things like your weight, obesity, right? And then there are non-modifiable ones. So those are more the genetic risk that you can't change, but whether you develop the disease or not really depends on a combination of all of these factors. So I'll just mention a few other sort of lifestyle factors. So alcohol actually has an impact on breast cancer risk. So the more alcohol you consume, the higher your risk is. And then physical activity is sort of the final one that has an impact. So people who are less physically active, and again, as a group, African Americans tend to be less physically active, have a higher risk. So there's really a combination of things that lead to the increased risk that we see in African American for these cancers. So, does anyone have any questions so far? Okay. Yeah. Right. 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 Exactly. So right. So I don't think we have a good understanding of why African Americans, in particular, girls, are starting their periods at a younger age. But starting at a younger age, less than age 12, is a risk factor for developing breast cancer because it increases the time that your body's exposed to estrogen, which is important in the development of it. So without of breast cancer. So without knowing why this is happening, I don't know that it's something we know how to modify at this point. So I think we're at the stage of trying to figure out why this is happening to our girls. Any other questions so far? Okay. So I don't know if you want to talk a little bit about the genetic risk part of it.
Sure. So maybe we'll just take a pause for a moment and let some other folks come into the room. Hello. What did you guys think about the morning session? It's good. 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 What what new thing did you hear that that you didn't know about before coming today? The vaccine. Okay. And what about the vaccine? Okay. All right. Okay. 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 And so, what other things that you didn't know about that you learned here today at the conference? How about you? Did you learn something new today? No. Okay, you're a researcher. Okay. Okay. So maybe instead of restarting, because we know we have a full agenda for today, and I understand that the previous session went a little over, and so we started just to kind of keep on time. But what I'll do is just sort of recap what we've covered thus far. So we've been talking about um, breast cancer in African American women and going over some of the risk factors for the disease. And we know we had sort of a nice little Q&A kind of a session where members in the audience sort of told us what they knew about risk factors for breast cancer. So how many of you have a personal history of breast cancer? How many of you have been diagnosed? So most people. Um, so then you all know that breast cancer is the most common disease among women in the United States, and you are among the survivors, and I think you should just sort of acknowledge that and give everyone a hand. Amen. Right. So some of you might be here because you're interested in loved ones, if you have daughters or sisters. We talked about family history being one of the most important risk factors for developing breast cancer, that if you have a mother, sister, or daughter who's been affected with the disease, that increases your chances of developing breast cancer. We know that your age at which you start your first menstrual period and the age at which you go into menopause plays a role in your risk of developing breast cancer, as well as whether or not you've had children and the age at which you've had children. So all of this is sort of, par for the course for you guys because you've been diagnosed with breast cancer, right? So one of the things that you might be interested in hearing about is how that information is being used to help women make more informed choices about treatment, and how that information can be used to sort of help family members make decisions about things that they might consider doing to reduce their risk of developing breast cancer. Has anyone ever heard of BRCA1 and BRCA2? Show of hands. Has anyone so what do you know about BRCA1 and BRCA2? They're breast cancer susceptibility genes that make some room here. Dr. Ferguson and I were sort of feeling very lonely in here until now. So we're glad that you all have made it. Just as a way of introduction, I'm Shanita Hughes-Halbert. I'm a faculty member at the University of Pennsylvania. I am a psychologist by training, and my faculty appointment is in the Department of Psychiatry. And I'm joined by Dr. Monica Ferguson, who is an internist in the Division of General Internal Medicine at Penn. And we've been working together for a number of years, or not a number of years, but 1 year, on trying to understand sort of breast cancer and cancer prevention and control among African Americans. So we've been one of the things we've been talking about are sort of family history and other types of risk factors that we can't change. But one of the things that we can change in terms of our risk of developing disease is our level of physical activity, our dietary behaviors, which all sort of feed into our body weight. We know that obesity is a risk factor for developing breast cancer after menopause. Welcome. And so one of the things that I was just starting to talk about is new types of services that women are using to help understand their risk of developing breast cancer, and information that they might choose to share with their family members. So I did a show of hands of how many women had heard about BRCA1 and BRCA2, which are two breast cancer susceptibility genes that were identified in the mid 1990s. And these mutations in these genes play a role in breast cancer development. And mutations in these genes can place women at an increased risk of developing breast cancer. Some of you might be asking, well, why would I want to know this information? I've already been diagnosed with breast cancer. Well, the reason why this information might be important to you is because BRCA1 and BRCA2 are passed down from generation to generation. And if you're found to carry a BRCA1 or BRCA2 mutation, it has implications for your daughters and your sons, as well, and your sisters and all of your relatives, really. So, has anyone ever had genetic counseling or testing for BRCA1 or BRCA2? Okay, so what did you guys think about that? What happened as part of that process?
You have to have at least you have to have two people in the family in order for the insurance to cover it. But it was interesting to find out that my father's sister had breast cancer and my mother had breast cancer. And so when I was diagnosed, they immediately wanted to do the testing to see. And I have mostly females in my family. So it was interesting. The implication grew beyond myself. It grew into them. Because if I was negative, then their chances were that they were also negative, that it wasn't a genetic factor for our family, which we did test negative. So the doctor explained it to me. One, it could have been my reoccurrence chances and where it might reoccur and the impact on my ovaries or my uterus for a reoccurrence in those areas with those genes were increased if it was positive. And then also in their starting to monitor themselves starting in their 20s as opposed to waiting for their 30s or 40s. They just took some blood.
So actually, the end result is you give a blood sample to have the test, but there's a process through which that occurs because we really want women to make informed choices about whether or not they choose to have testing for BRCA1 and BRCA2 mutations. I don't know quite where to stand. Can you turn it off? No. Okay. So one of the things that's really interesting about BRCA1 and BRCA2 is that they are inherited both in men and women. And so although male breast cancer is very rare, men can still be carriers of mutations in those two genes and then pass those mutations on to their offspring. So it really raises the point of us knowing about all of our family history and talking and sharing information about our experiences with different diseases, and not just cancer, but with all types of diseases. So we need to know about who has had diabetes, who's had hypertension, who's had heart attacks, so that we can be informed about our risk of developing all different types of diseases. But the question was about what sort of is, so certainly BRCA1 and BRCA2 is a blood test that's done in a laboratory. But there's a process, and that first process is called genetic counseling. And genetic counseling is really an educational process. I've said process like twice now. I can't think of another word. But it's designed to help people make informed choices about whether or not they want to have genetic tests for BRCA1 and BRCA2. Some of the things that would be covered as part of genetic counseling is what are the advantages to me having this test? Some people say, well, I'm doing all of my cancer screening tests. I get my mammograms each year. I've already had breast cancer. Why would I want to have it? And just as your experience described, is it has implications for your family members. So it helps you to sort of think about and identify the pros and the cons for you as a reason for having genetic testing. The other thing that happens as part of genetic counseling is that you have an opportunity to identify family members who might be at risk for carrying a mutation if you're found to be a mutation carrier. And so that can be helpful to think about, well, who would you want to share the results with? Who should you share the results with? And helping you to think through how you might cope with some of their reactions to learning this information. How many of you have family members who just don't want to do anything about their health, who don't want to know anything about anything? Most of us do. And that's, it's really common. We all react to, health and our health risk in different ways. Some of us want to know all the information that we can, and some of us just don't want to know anything. And so genetic counseling can help you think through how your family members might react to learning about their risk of having a mutation and subsequently their risk of developing breast cancer. And then help you think through how you might share that information with them and how you might deal with their reactions. The other thing that genetic counseling will do is help you to understand what options exist in terms of managing your risk if you're found to be a mutation carrier. So one of the things that you might have, has anyone ever talked with you about, or some of the conversation might be having your breasts removed as a preventive measure or having your ovaries removed as a preventive measure. And so those are big surgeries to have and big decisions to make, and genetic counseling is a way for you, provides a context and a space for you to think about all of those choices. So, what questions do you have for us? I've sort of talked about breast cancer and genetic counseling, but what questions do you have for us? Yes.
So you mentioned there were some nutritional sort of guidelines that we could follow. Could you talk a little bit more about that?
So we all should be eating a healthy diet, and maybe Dr. Ferguson can chime in here about what the recommendations are. But it's really sort of what's recommended for the general population in terms of eating lots of servings of fruits and vegetables, eating 5 servings of fruits and vegetables, at least 5 servings, thank you, servings of fruits and vegetables per day. The other thing, you think about diet sort of and physical activity going hand in hand, right? So in addition to eating at least 5 servings of fruits and vegetables per day, we want to be physically active. And physical activity, the recommendations are to engage in moderate physical activity for at least 30 minutes per day, 5 days a week at a minimum. So, what's considered moderate physical activity? Does anyone have ideas about that? Because that's confusing to me. Walking. Say the what? Yoga in your seat. Okay. I've never heard of yoga in your seat. What is that? Okay. 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 Water aerobics. Things that get your heart pumping. What else? Running. So depending on your speed, that could be vigorous. So if you're going, if you're going slow, like my running speed, that'd be moderate. Monica's might be vigorous. What else? Going up and down stairs with the Stairmaster. Okay. Any other ideas? House cleaning. That's right. House clean. That's one of the things. So that's actually a very important point because we don't think about house cleaning. So I have a funny story. I don't know if I should say this on the. No, I won't share it on the screen. I'll say it after we shut off the screen. After we cut off the screen, I'll tell you my funny story. But one of the things that I think is really important is for breast cancer survivors to recognize is that it's okay to be physically active, and that it's important to be physically active. Certainly, you want to talk to your medical oncologist and all the members of your healthcare team about sort of your level of physical activity, but it's important to be physically active. And we know that it can be hard to keep up that level of physical activity while you're going through chemo because you're very tired. And we know that that's the case. But there's, even small things during that time period can be helpful. There's a group of investigators here at Penn who looked at the effects of sort of physical activity and lymphedema. How many of you have had lymphedema or experienced those? So it's a very common side effect of breast cancer treatment. And her research showed that being physically active using strength training was actually beneficial and helpful for addressing some of the side effects of breast cancer treatment, lymphedema in particular. So what that means and the way, we think that the implications are is that it's okay to use weights while you're, in the survivorship phase. So, and that's another type of physical activity that we should sort of keep on our radar screens at all points. You don't have to have like a fancy set of weights. You could use soup cans to sort of add some strength training. You can use those bands. I mean, so there are all kinds of things that that we can do. You look like you had some experience with that.
Well, for me, when I just finished all my treatments in April, and I had chemo first, and my objective was to work out while I was going through chemo, so that I could go in strong and feeling strong afterwards. And I mean, I had the side effects like everyone else of chemo, but I did work out as often as I could, and I mean, I feel great now. I work out like a fiend. It doesn't look like it, because I'm going through because I'm going through menopause, and the weight is there, and I eat right, I do all of those things, but I think my objective is still just being as strong as possible. I do carry, I'm concerned about the weight, but I'm concerned more being strong and active, and I try to get more people involved. Just get out, do something. Yep.
So I think your example is really important because we often think about, well, I'm not losing the weight. I still am bigger than what I want to be. And that's, it's important to still sort of stay with the program because your body's changing. Menopause is, you know, I don't even know what to say about menopause. Maybe you can say something.
About menopause?
So, but I think one of the things that is really, our bodies go through so much. Certainly, as a breast cancer patient and survivor, your body is changing. And I think what we can do is continue to engage in a regular program of physical activity, because even though the weight isn't coming off, is having, we believe it's having a beneficial effect. Exercise does more than just change your body. It helps with your mood, and it can help. It's just it can raise your spirits. Um,
What is the if you carry the gene, what is the percentage rate of your cancer reoccurring by carrying the gene?
So, what's the recurrence rate among mutation carriers? And you're going to catch me here because I don't know this specific statistic, but I would say that it's increased, so that mutation carriers have an increased risk of developing contralateral breast cancer or for developing a recurrence. And I can't cite you the specific statistic, but there is an increased risk among mutation carriers. I don't believe it's more than 50%. No.
Genetics, and there's a lot more going into the genetic testing, just not you, it's your family history, how many, what stage, you had or the family members had. So it's a lot more that would determine that percentage.
So, contralateral, so developing breast cancer in the opposite breast. So actually your point is really important, that, one of the factors that's considered in genetic testing is sort of your family history. How many people have had breast cancer? How many people have had ovarian cancer? Their age of onset. So the things that sort of makes us suspicious about the cancer being due to hereditary factors is that there are multiple cases of breast cancer and ovarian cancer in each generation, and there's an early age of onset. And so early age of onset is usually considered being diagnosed before the age of 50. But what happens is once you're sort of identified as mutation carrier or a non-mutation carrier, um, that sort of changes your risk of recurrence more so than your family history, because we know that there are specific risks associated with being a BRCA1 or BRCA2 mutation carrier. So that is some of the sort of the caveats around it. So one of the things that, we often encourage women to do who've had a personal history of breast cancer is schedule an appointment to talk to a genetic counselor, because that's really the person who will help you to sort of work through your family history to determine if it sort of meets the criteria for being what's called a hereditary breast cancer family. And if you do meet the criteria for that, then you can make decisions about if you want to have genetic testing. And if you don't, then some women find it reassuring to know that they don't meet the criteria for having a hereditary breast cancer family. It doesn't answer the question of why you develop breast cancer, but it can sort of might ease your mind about your other family members that you're thinking about.
It had that ease effect for my mother. She was re-diagnosed the same day I had an abnormal mammogram, and she felt as though she gave me breast cancer. So that made her very depressed. So when the test came back negative, she felt a sense of relief that I didn't give this to you, and I didn't prepare you for this to start to come at this age. So that was beneficial. But I'll be honest, once they said negative, I really didn't want to hear anything else. I was happy. But it would be neat. I heard of the one study where the woman was looking at, because we're both triple negative, that was their other reason for wanting to test, was that, well, I wish they could also then align it to see, did we hail out of Ghana or out of West Africa where they're starting to see a rise in triple negative breast cancer? And is it maybe not a BRCA1 or 2, but maybe that genetic bloodline that might be causing that?
You raised the point about triple negative breast cancer, and I wanted to talk a little bit about that. Did you have a...
Oh, yes. In my family, we had breast cancer in my family. I had breast cancer for 20 years. She had breast cancer. I had past two sisters with breast cancer. I had another sister had ovarian cancer. It just run in the family. And last year, I was diagnosed with a new cancer. And it's called small cell. And they don't know too much about that. But I'm still going to treatment with that.
Well, we are so glad that you're here.
Where I want to go. If I feel bad, I stay home. Then I feel good, I get out and go. I told him I ain't sitting home. I just go. I said you have to keep moving. You can't let the cancer beat you. You got to beat it.
And that's what a lot of women have shared with us. That's important, is to keep up your normal routine. That you can't let the disease beat you, but also you have to be within reason. When you don't feel like going,
I don't go. Then I feel like going. I say I ain't staying in this house. I just get out and get this little walk on, and then we gone.
That's right. That's what you have to do. You have to keep on keeping on. So your family history, what you described, is one that we might be suspicious about as being a hereditary breast cancer family. Mm-hmm. So,
because I was going to the risk factor seminar. I was bopping around, but they were talking that they were looking for families to volunteer because they needed it for research. So if you and so many of your family members have all these different types of cancers, you should, I'll try to find that doctor, your family, you should really volunteer it so they could take a history. Because you and your family will only help, your legacy was that you'll help other families and help other individuals try to fight the various diseases. But I was just there when the doctor was pulling the plug, saying that they need families with, people having history.
And so that's really an important point, is that one of the difficulties with understanding why we're diagnosed with triple negative breast cancer more often, why we're diagnosed with more advanced stage disease, is that there are not a lot of us who participate in clinical trials. I'm not here to do a plug about clinical trials. All to say is that, it's really important for us, well, I guess I am doing a plug. It's really important for us to think about participating in studies so that, we're represented in the work that's being done to understand what causes disease and to develop treatments for curing those diseases.
Two questions. Is there an increased risk factor for families that intermarry?
So for families that intermarry, not that I'm aware of in terms of breast cancer.
And the other is there a specific trial for triple negative?
So that's a really great question. There are studies that are being done to understand triple negative breast cancer. And I can't cite you the specific ones, but I'll refer you to Penn's website, the OncoLink website. They have a clinical trial locator or matcher or whatever. And if you put in the types of things you're interested in learning about, the types of studies that you're interested in learning about, it will match you to those. The other resource is clinicaltrials.gov. It's www.clinicaltrials.gov. And that's a matching is a warehouse for information about studies that are being done all over the country. And it might be helpful to find, you can look, sort of put in triple negative or breast cancer and find studies that meet those criteria. Yes. So I'm going to turn it over to the internist here. Talk about triple negative breast cancer. So triple negative breast cancer. Has anyone been diagnosed with triple negative breast cancer? Let's hear from.
Well, it is not estrogen positive. It's not progesterone or HERP, and it tends to reoccur more. It's more aggressive, and within the first 2 years, if you're going to have it return, that's usually when it shows. Not just past my 2-year mark.
Help with that. So if you're HER2 negative, there's not anything to give you.
So it makes treatment more challenging, yes. And it's usually a more aggressive form of disease. And so
well, there's no post treatment. There's really no definitive current treatment. So they just kind of give you the best shot that they have. For me, it was high dose stents every 14 days. Some women do every 21 days. And then when you're done, you're done. And I was like, so CAT scans every 6 months? And they were like, no, when it comes back, it's back. Results the same whether we CAT scan it and check it or you come in with symptoms. So it usually comes back as fires because it comes back in multiple organs at the same time. And then they just go around putting out the fires. And that's when the gene testing would have been beneficial because they have different treatments for people who are BRCA positive to try to help suppress that. But however, it's just when it comes back, it comes back. Or you might be one of those people that it won't come back.
So you asked the question, what are the symptoms? There are really no specific symptoms that are different from any other type of breast cancer. So, but it raises the point of what are the symptoms of breast cancer? So what are the symptoms of breast cancer? A lump? Could be a lump. Nipples turn in. A discharge from your nipple that is not usual. Dimpling. So we all know the signs of breast cancer. But your questions and the discussion, I think, really raises an important point about really having a very good relationship with your healthcare provider team. So you need to understand, what type of cancer do I have? Is it triple negative breast cancer? What stage of disease have I been diagnosed with? And what are the treatment options for my particular type of breast cancer? One of the things that's become really interesting is, after you finish treatment, sort of like everyone's happy and glad, and you're like, I'm done with that. And then so you go on to your, back to your primary care provider. So how has that transition been for you guys, going back to your primary care provider? Does anyone have? Not good.
But I lived in the Washington area, and I started at GW. I had my surgery there. Then I had my chemo with an oncologist who had her own practice. And then I had my radiation at the Virginia Hospital Center. And I just never quite felt that I was not adrift. So I've been back 2 months here. And I don't see my internist until the end of November. So I'm just definitely not in control.
So, but I think that might be a common experience. Let's hear from someone else.
My experience with my primary doctor has been really, really good because I'm one of those kind of people that go to the doctor all the time. And that's why it was a surprise for me to find out that I had breast cancer because I was between mammograms. And she was the one that actually picked up on me just going ahead having a scan. I had another mammogram after I was diagnosed with cancer, and they still didn't know where it was, where it originated from, but she was there with me the whole time. After all of my treatment, I have gone back because I had a deficiency in vitamin D, and I'm sure a lot of people know that that's like a precursor for breast cancer. Now my vitamin D levels are up. I was taking a multiple vitamin, but she stopped me from that because of the recent reports about women taking multiple vitamins. And it's just been a really good relationship. And you should have that. You should have your primary and your oncologist, all be together so that they can all work together for you.
That raises some.
My primary physician, who I've been with for 19 years, was very, very disconnected from me. There was no reaching out or even sitting down because I had to find a surgeon and I had to find a plastic surgeon and I had to do it all on my own. And I left an email and a phone call, never heard. So when I went back, it was like a long time, like 2 months later. And also I had complications, I had a blood clot as soon as I came home. And it was like, when he saw me, it was nothing there. He didn't ask he asked how I was doing, but in terms of what I've been through. And I just said, it's time for me to leave. But it was hard for me to do that. I have a little problem there in terms of pulling away. And so it something happened again. And then when that happened, I said, no, you really have to find a doctor you're going to work in partnership with. Because I've had cancer 3 times. Oh, yeah.
Did you express to your primary how? Good.
And,
Uh-huh.
I cried a little.
Yeah.
And he tried to be attentive.
Mm-hmm. Too little, too late. Yeah.
I felt that he would draw me away from the hospital setting after 19. He wouldn't even know my name.
Wow. I'm sorry you had such a unfortunate experience. I wanted to make a few comments. So one, getting back to the triple negative, which as an internist, I'm not as familiar with the lingo. I do know about ER positive and PR negative, the receptors, and what that speaks to for people who may not know is when you're diagnosed with breast cancer, they do specific testing on the cancer cells to find out whether they have receptors for these particular hormones. And if they do, then that helps guide the therapy. And I think a lot of what we're talking about kind of speaks to something we mentioned earlier, which is often, unfortunately, African Americans don't necessarily get the prompt, high quality treatment that we deserve, and that's almost certainly a factor in why we tend to do worse once we're diagnosed with the cancer. I think another factor is often there's not the communication that there should be between the specialist, the oncologist, the surgeon, the primary care physician. I think that's a big problem. I think it's something that, again, if you're receiving care at a place like Penn, more and more that's likely not to be as big of a problem as the departments are integrated. But I've had a lot of patients who've gotten care elsewhere, and it continues to be a big problem where one physician who's responsible for one part of your care doesn't know anything about what's happening in the other part of your care. I think another thing that I just wanted to bring in is how often we're not good about educating our friends and families about these things too. So we were kind of having a little side conversation about how often we don't know our family history. So here it's very important as far as our risks for a lot of different diseases. And every single day I see patients and ask them, well, is your mother still living? No, she died. Would she die from cancer? What kind of cancer? I don't know what kind of cancer. I mean, it's really important for us to make sure our family is aware. And I think particularly with cancer, there's emotional parts to it. There's maybe we may think it's better not to worry them, so we won't talk about it. I think sometimes there's some, I don't know whether embarrassment or shame are sort of the right words, but people definitely have emotional feelings once they've been diagnosed that may make them somewhat reluctant to share that information. And it's something that it's really important that we really make an effort to do that. So a lot of people have.
Going to what you were saying about embarrassment or not knowing about family history, that's an issue that I'm coming up with. When I was just diagnosed earlier this year, and I just turned 48, so my mother is 91, and she's doing fabulously. So, but we're trying to determine if there were any other female members in our family that might have passed or had, cancer. I know my grandfather's had it. Had cancer, but I didn't know of any history of breast cancer because my mom always tells me a lot of people didn't talk about, the illnesses in our family. So that made it difficult to determine what's going on.
I know that in our family now we have nothing, no aunts and uncles left. We just have all first cousins. And it's kind of hard to just sit down and talk about it, I guess. I've never, 13 years, and I've never talked to them about the fact that I had cancer. I guess if it came up or something like that, I would mention it, but I mean, I just never took it on my own to just, hey, I have cancer, you want to talk about it? Or, how many of you people here? No, it's just not a thing that's done, but it would be good to know. Yeah.
It's still a lot of people that have trouble. They used to say the big C. Yeah. But it's still a lot of people that have trouble saying cancer. I'm not one of them. I talk about it all the time, because I want to encourage people to go and get their mammogram. Because every time that it was discovered, it was behind the mammogram or the pap smear. So, it's important.
Yeah. Well, I know you've had your hand up a while, so we'll move over here.
I just want to say my doctor told me at age 40 to start having a mammogram every year, and I've been doing it ever since, along with my pap, all in the same week. I'm now 73, and I'm 20 months cancer-free. I'm the only one. My mother passed away last year at age 93. She smoked until she was 84. She left out of here with everything she came in the world with, including her teeth. Now, my sister passed away this year, but she passed away from a stroke and complications. And my mother was the last one in her family, so it's just me. But I have 3 nieces, my sister's daughter, so I'm telling them now, you have to go. But I started at age 40. I had a good doctor. And my primary physician now, along with my gynecologist, they work together too. And it was my gynecologist when I went, and they called her, And she said, I want you to go back because they see something and they want to make sure. So I had another mammogram and an ultrasound. And in my right bed, it was so tiny, you could barely see it. But the radiologist, I made fun of him when he came in because I said, where's this old man going? But that old man called me and told me just what it was, the calcification, because I had it in both breasts. My husband has been with me from day one since we retired. He goes with me for the mammogram and my pap. So I said, let me go get my husband because I didn't hear nothing. And I said, you tell him what you just told me. And this is why he's here today. He went with me every day for my radiation for 6 weeks. So this is my support here.
I just wanted to say that originally I was going every year at 40 to get my mammogram, and it never picked up anything. And one day I felt a lump, and I told my GYN, and she says immediately just go to a surgeon. She didn't examine me or anything. I went to a surgeon, and I must say he was a quack as far as I'm concerned, because he said, okay, we're going to come in, we're going to do the biopsy. He did the biopsy, and he took like a week before he called me. And when he called me, he just called me in the office as I had the results. Knowing what it was, he didn't kind of prepare me. And I went alone, and it was very upsetting. So to say that, the mammogram doesn't always pick it up, and that you have to know your body and understand what you feel and know that, because if I hadn't known that I felt something that wasn't there, I would have never picked it up. But I'm 6 years of a cancer survivor. So.
Hi, I just wanted to speak on the mammo. I'm a 2-year survivor, and I did my annual mammo. The mammo was negative, but my surgeon, in addition to doing your mammos, she also does the cancer, 2629 or 2729, and that showed elevation, which led me into doing CT, PET, the whole drama, and I just have a nodule under my arm, so we're doing a biopsy on that. So as a cancer survivor, when you do your annual mammo, that may be something that you want to ask your physician, do they, in addition to just doing a mammo, because the mammo was clear. Mammo showed negative. But because my surgeon does the cancer serum test, I think it's cancer 2729, in addition to it, that's what raised the red flag to go into other testing. Exactly, because I'm a triple negative, and I'm the triple negative.
Post-treatment, what is the frequency of visits to your physicians, your team? And can you expect to have a physical exam at each one of them?
I think that probably depends on a number of factors. What stage you are when you're diagnosed, and what kind of that dictates what kind of surveillance that you need. I think the whole idea of the physical exam is, I don't want to say controversial, but I think the reality is that the usefulness is fairly limited as far as picking up a recurrence. And so I think from the patient's point of view, we have an expectation that that's going to be part of any evaluation. So I get a lot of patients who will come and tell me they saw the doctor who didn't do anything. And I'm like, what do you mean he didn't do anything? And what they mean is they didn't do a physical exam. And, I think there are reasons to do it, but I think the reality is that it's unlikely that that's actually how you're going to pick up the recurrence. So. Mm-hmm. Yeah. You're like, wait a minute. And I think, right, I think a lot of times the focus is more on the kind of the testing, the test results and evaluation and what the next steps are. And so, again, the physical exam is just kind of becomes less important.
I know it's surgical or medical or radiation oncologist. You're seeing one of them alternating around, and then you go down to every 6 months and every year. So the every 3 months, it's a whole new breast exam from before you're diagnosed to get to the feeling your breast is much more painful. They're really trying to feel what they can, I forget what you want to call it, whatever.
Palpate.
Yeah, palpate, and they're really pressing and searching.
And I'm sure the standards depend on the institution that you're receiving your care as well. So there's definitely some variation with that.
Is there a magic number that you had that a woman should start, just like to help black men usually around 40 to start taking a prostate?
For mammograms? So right, so age 40, yeah. And I don't know that we have time to sort of get into the controversy over. Yeah. Well, and I will just make a few brief comments, which are so I'm sure you all heard from the U.S. Preventive Service Task Force, which is a group that looks at the evidence and makes recommendations for physicians as to how often screening tests should be performed. So the first thing is this is screening tests. So this doesn't mean if you have an abnormality, if you have an increased risk for disease, if you have a family member who has breast cancer, this doesn't apply to you. This is people with no reason to think that they have breast cancer, for example. And the recommendation, which is actually similar to what the recommendation is for prostate cancer, was that starting at age 40, you discuss with your physician whether it's appropriate for you to have mammograms once a year or every 2 years. So that was sort of what their recommendation was, but I think it got kind of somewhat misconstrued into women don't need mammograms starting at age 40, and that's not what their statement was saying. Actually, are we out of time? Uh-huh. Mhm. Mhm. Mm. Mhm. Mhm. Yeah, so it can happen at any age, and there's some debate about at what age do you stop screening. So. And that's something, again, that's not actually a new recommendation, and it depends on, again, the risk factors for cervical cancer. So if your cervical cancer is actually more common in younger women who tend to be more sexually active. And so if you're having multiple partners, then 3 years is not the recommendation for you. But it's actually been for a while that if you have a stable partner, then you can, and you've had normal ones, you can go 3 years. But again, it's really more individualized than I think we try to make it. So it's really sort of up to the physician to look at the particular person and say, well, for you, you should be getting a pap test every year. For you, you should be getting a mammogram every year. And again, discuss with the patient, this, you could have it every year, you could have it every 2 years. So. Well, but that's an individual choice. I mean, I have lots of women who don't want to get a mammogram every year. So, obviously in this group, we're all promoting it. But again, every day I see a patient and I say, you haven't had a mammogram, you're due for one. I don't want one. So. Right. Right. Mhm. 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 Again, it's a choice. I mean, but they didn't say you can't have a mammogram if you're 40. It's talk about it. So you're someone who would say, I want one every year, and I've not had any. There's also, I think, a misperception that the government is doing this to save money. And I've not had any problems with patients having to pay for mammograms at age 40. So. Nope, I haven't. I've not. Nope, that's not the case. Because So, right. So again, that's not screening though, because you had a risk factor. So it's right, right, right. Earlier. Right, right. Mhm, 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 mhm. Right. Previous ones, yeah. So.
So all of you have raised some really important points about taking an active role in your health care and being involved in knowing what the options are and talking to your providers. You know, it used to be where, you know, when we went to the doctor, it's like, well, they just did things and ordered things, and things happened, and we didn't understand why or what was happening or why. Um, and we know that sort of that when you hear you've been diagnosed with breast cancer or any type of cancer, that you just sort of shut down. You don't hear anything else after that. Um, and that my father was just diagnosed with prostate cancer, and when he told me that, he was like, "Well, what does the doctor say?" He said, "I have no idea." What he said afterwards, but you know, we have to after we get over the shock, we have to get involved, and we have to know the protocols and understand what the choices are and make choices for ourselves. The whole issue about mammogram is a very important one. I mean, the recommendation is this, but we know our bodies, we know what's going on, and we know our family histories. And so we have to be proactive and talk to our providers, talk to our doctors about, I think I need to have this done, or I think I need to have a mammogram. If they don't recommend it, you need to know why they're not recommending it. You need to talk to your primary care providers. They can help you navigate the system. And if they're not willing or unable, you need to find another one. So what's a good way to find the primary care provider? Talk to your friends. Talk to your family members. Who do they like? Who do they not like? Why do they like this one and why don't they like that one? So we have to start talking to each other about our health and our health issues. Um, so we don't know what time we're supposed to end, but but we think it's soon. So we want to thank you for coming and thank you for sharing your experiences.